Dr. Tricia Petzold, she is a family medicine practitioner at the Snowbird Medical Clinic in Utah. And someone we've already met, Elise Flemings, who's the executive director of Healthy Acadia in Maine. So I think coming at this from a public health perspective, I've been very interested and moved by all of the research that was presented and all of the other interesting facts that we've heard today. But what I find particularly disturbing are the disparities. The disparities in prevention, the disparities in environmental exposures, the disparities in healthcare access and screening. And so this panel is talking about something that's near and dear to my heart as a public health practitioner. And I just want to thank them all for the work that they do. So I would like each of you to take about 30 seconds to a minute or so to just introduce yourself and tell us a little bit about your work and maybe what keeps you up at night in terms of some of these issues. So should we start at the end? David?
I'm really honored to be here. Wear several hats. Obviously, as introduced, the director of Telehealth at the Karen S. Rubin Center for Telehealth at the University of Virginia, and I'm very honored to be a part of that and be a part of building the bridge to places of geographic disparity, those places where both individual care and access to health care are a demanding job. And so that's really nice. I'm also a co-founder and part of the Healthy Appalachia Institute, which is a public health institute in the coalfields of Southwest Virginia in the heart of Appalachia. And the most important thing about who I am and why I'm here today, I wear a hat as a kid from Bluefield, West Virginia, Pocahontas #9, best bituminous coal in the world, in the hearts of the coalfield. And my best friend, Jimbo, who I grew up with, his wife died of head and neck cancer last week. I go to the funeral Friday, and this is a cause to get specialty services, to get the right care to the right person at the right time, no matter where they are.
Thank you. Grant?
So I'm Grant Harrell, and I'm a faculty physician at the University of Florida in Gainesville. And like David, I wear several hats, but the two that relate to this specific topic is, one, my clinical practice in a small town in Dixie County, Florida called Old Town, which is a very small town and a very old town, as it's mostly made up of elderly folks. And so I'm in one of those places that David's talking about, where we have a lot of disparities in terms of getting people services that they need. The other hat that I wear is director of the Mobile Outreach Clinic, which is a clinic on a bus in Gainesville, Florida, and it goes to various hotspots around the town where we've identified through GIS mapping where there are specific disparities, both related to health in terms of uncontrolled chronic diseases, higher rates of low birth weight babies, and also those things, same spots are associated with some of the highest crime rates, domestic violence calls in the city. And so our mobile outreach clinic goes to those hotspots, and we specifically seek out those patients that are uninsured, and we provide free care to those folks. And so I'm particularly passionate about the issues that the uninsured face in terms of getting high-quality health care. The things that keep me up at night and that I'm constantly thinking about are how do we address some of these social determinants issues that really are the underpinnings of why we have so many health disparities in our both rural and our urban populations.
Great, thank you. Tricia?
My name is Tricia Petzold, and I am a family physician trained. I'm a family physician trained, and I have, the last 10 years I've been working in an emergency department in a hospital, and have noticed that 50%, maybe 70% of the patients that I see have a chronic illness, and I just didn't feel that I had the right tool to treat and really care for those patients. And so I've gone back and trained in functional medicine, and I teach integrative medicine at the University of Utah Medical School. And we focus on nutrition, movement, stress reduction, sleep science, teaching medical students these things so that they can prioritize these things and talk to patients, their future patients, and we can bridge that disparity gap between who gets education, what patients get education on preventative medicine, and by teaching medical school students, more people will. Thanks.
Great, thank you. And last but not least, Elise.
Great, thanks. Yes, so I'm Elsie Flemings with Healthy Acadia. Those of you who are here this morning heard a little bit about what we do in very rural northeastern Maine. So we're a community health organization. We're boots on the ground. We really rely on the experts in this room and all over the country and beyond to lead the way in terms of science and research, and then we implement that. And sometimes we're also part of and looking at exploring innovative approaches to address the community health challenges that we face. So we are a very rural region. To give you a sense, so I serve primarily a 2-county region out of 16 counties of Maine. Those 2 counties are nearly 3 times the geographic size of Delaware, with 9% of the population. Wow. Geographically, it's literally half the size of Maryland, with 1.4% of the population. So if you think about that, it's small numbers of people spread out over a very, very wide region. You think, and that also translates into, at the state level, you have many fewer people, less of a tax base, with a huge geographic spread. So you're trying to build roads farther with fewer people to support those roads, the infrastructure, let alone thinking about health services and prevention services and healthy activities and community centers for youth to be able to engage in healthy activities and senior centers for seniors similarly. So those are so that's the sort of geographic disparities that we face, and we have other disparities as well. We're the oldest state in the region, and my neck of the woods is even older than the average of Maine. Lots of needs there. We have high levels of arsenic in our well water. We have many people on well water, part of our rural nature, many more than general, and then high rates. So looking at how we address those issues. We have very old housing stock, which comes with some other issues there, high rates of radon. So we're looking at a lot of challenges, and at the same time, we have an incredibly vibrant, active, committed, independent, incredible population, incredible community members. And so we really work in partnership with our community members, with many, many partners. We aren't direct providers of healthcare generally, but we partner with our health centers and our hospitals to be able to expand access, to be able to understand what the needs are, and really hone in on all sorts of community health initiatives that build healthier communities, that make sure all people have access to the healthy choices, and then also address things like expanding screenings and providing cancer patient navigation services. So really along the continuum of care, from early childhood work through the disease and recovery process. And so I could go on, but I'll stop for now and come back. But it's just, in terms of what keeps me up at night, sometimes extra grant writing keeps me up at night while I'm securing the resources that we need. Again, we do things almost entirely by grant. We're one of the few states that doesn't have county public health departments, county-funded public health departments, so it's nonprofits. We work in partnership with the state, and things rise and fall depending on who's passing the budgets, but we do work and leverage resources at the state level, but then beyond that, we really need to be grant writing and fundraising to be able to provide the services that our communities need. So that's one thing, and other than that, just the disparities that we continue to see, even as we do this work dedicatedly with our volunteers and our staff. There are still many people not accessing the kind of services that that can save their lives and that can extend their lives and improve quality of life, and and kids who aren't getting the opportunities that will enable them to reach their potential. So we always have more to do, and so I'll end there. But thank you. It's an honor to be here.
Oh, thank you, Elsie. It's obvious that you're truly passionate about all of this, and I think you've given us a nice segue into what I was thinking would be my first question, and that is actually for David. And I was wondering if you could talk to us a little bit about the particular disparities that you're seeing in rural health when it comes to cancer and cancer screening.
Yeah, I think everyone in this room, the reason why we're here is we understand that place matters. Mm-hmm. And within the context of place, then the access to care within that place sets the stage, whether it's preventative care or whether it's early diagnosis, whether it's screening. And so the absence of those resources, and all of us on this panel work in environments where that access, you got to get it on the bus. You know, you stress to get it out to build a road or, you know, to be able to reach people with the resources they need. And so that absence of resource is our greatest challenge, because everybody in this room knows that the means to prevent many cancers are there. And then getting people to care. Once they get the care, secondary prevention is very possible. We can begin to think about cancer as a chronic disease. But we have to reach people in the first place. And it's all in our pocket. And we don't realize that, right? The revolution about what we are looking for is with us. I don't know if you guys saw, walking through the building today, everywhere I went, there were people with those T-Mobile pink 5G T-shirts. They're here ahead of us to say that 5G is coming. And when I talk to people, they say 5G will be greater in its impact than the Industrial Revolution. And so why should it be that people with cancer or people at risk for cancer or people who need genetic counseling or people who need early diagnosis or breast screening or colorectal screening should not have access to it, when the ability for us to use digital technology is going to be so powerful? Now, mind you, the gap still exists. We have every reason to believe at this table, right, that 5G, Acadia is not going to be the first place that they're going to drive 5G, that rural Florida is not going to be the place. You're from?
Utah.
Utah. Oh, we know it's going to Utah, you know. And so that challenge, that isolation is not only in relationship and proximity, it is also the virtual isolation and the reason we need right now to be very aggressively moving to drive technology into rural communities and urban communities that suffer from disparity.
Thank you. Grant, what other sorts of disparities are you particularly seeing, you know, other than geography? And how is your work addressing that?
Sure. So in my capacity with the mobile clinic, which I mentioned is targeted more towards an urban population, we don't necessarily have the location issues, but we have a whole host of other issues. One of the main ones that we deal with, of course, is lack of insurance. Because we predominantly provide services to people without insurance. That's why we exist. That's why we started the program. And it's a very powerful disparity. It explains definitely some of the variance that we see amongst disparities in cancer screening rates. I mean, the American Cancer Society does a tremendous job of collecting data on the various types of variables that influence various types of screening rates. And the one that is consistently shown to be associated with the biggest disparity is, of course, insurance status. And you look at colorectal cancer screening rates, it's about a 35% difference in the most recent data from 2015 that they have, which takes insurance into account. About a 35% difference between the insured and uninsured and whether or not they're getting the necessary colorectal cancer screening. When you look at breast cancer screening, again, close to about 35% difference. And these are huge numbers, right? Cervical cancer screening, although rates in general are much higher for cervical cancer screening, the disparity between the insured and uninsured is still quite high, about 25 to 30%. And so we know that that's one, big piece in the explanation of disparities. But again, it's not the sole explanation. In fact, it's a proxy explanation for many other things. It's a proxy for employment status, for housing status, for educational level. All of these things also explain a lot of these disparities. Those same data sets which look at insured versus uninsured, they also look at educational level and how that relates to somebody's likelihood of getting screened for cancer. And again, the disparity is pretty huge when you take the lowest educated, which is defined as some high school or less, versus the highest educated, which is considered a college degree or advanced degree. You see about a 25% difference in colorectal, breast, and cervical cancer screening. And it's very interesting that as you just step up the education level, to a high school degree and then maybe associate's degree and then finally that college degree, with each little step up, you narrow about 5% more screening that occurs. And so, we, of course, in the mobile clinic and out in my rural clinic in Old Town, we see a lot of those educational disparities. I have very few patients that have college degrees, right? I have very few patients with stable employment. And, of course, we have almost no patients in the mobile clinic with insurance. And so that's just sort of a few of the really important factors that we think about that explain some of these disparities in our population.
Great, thank you. That leads me, I think, Tricia, and I didn't mean to go right down the line, but that's just kind of the way my thinking is working. So we also know that lifestyle factors make an impact on cancer risk, but I'm wondering if you could talk about how healthy habits moderate that risk, and then maybe if you're ever seeing intersections between disparities and cancer prevention lifestyles. And what I'm getting at is I'm aware from the public health lens that oftentimes we see healthy lifestyles, once again, correlating with education status, income, and things like that, just literally because of circumstances. So I don't know if I made that clear,
Okay.
but...
Yeah, I'll give it a try. So we've known that that lifestyle impacts the risk of developing cancer, and Walter Willett from Harvard documented this in 2003, saying that up to 70% of some cancers can be prevented with lifestyle alone, and half of that would be attributed to not smoking tobacco or being exposed to smoking tobacco, and half to nutrition, physical activity, and moderating alcohol intake. And since then, for the last 25 years, there's the World Cancer Research Fund, and they've from the UK, and it teamed up with the American Institute for Cancer Research, and that is a continuous update project that has taken, as we know, it's hard to take lifestyle patterns, nutrition patterns, and put it in a randomly controlled trial, any blinded trial, because it's just too long of a duration, and it's too hard to put someone on a dietary pattern and keep them on there for 30 years and then get results. So what they've done is for 25 years have looked at data, a lot of it's epidemiological data, a lot of it's cohort studies over time, and accumulated 25 years worth of studies on how nutrition impacts cancer. And there's this great online resource that is a link that is very interactive. It's the graphics are colorful. They have slides to share if you want to share this information. And there's a lot of data they share in terms of what they're basing the recommendations on. Things like 60% of endometrial cancer can be attributed to obesity. 70 or over 85% of lung cancer can be attributed to cigarette smoking. 20% decrease in the rate of breast cancer for women who do moderate or vigorous exercise, both premenopausal and postmenopausal. A meta-analysis on cohort studies that show that there's a 15 to 20% increase of colorectal cancer with 100 grams of red meat or 50 grams of processed meat, and other things, non-starchy vegetables and exercise reducing colorectal cancer. So lots of information about that, and then information about how to share it with patients. It's very accessible to patients. It's very accessible to policymakers. It's very accessible to providers to have something to help patients educate them, and who gets that education, I think, is quite a disparity. And one is access to the physician, and another is, does your physician put that a priority to discuss when they come in? And I think certainly in my emergency room hospital was a rural setting. It was sort of right in a line between rural and a higher density population, and so we got both, but it was distinguished as rural. And there was quite a disparity with patients who would come in who had some knowledge of that, and patients who had zero knowledge of that. And I think that reflected how far along on the continuum of chronic disease we'd see them when they presented in the ER. But I think in general, all of us as providers have a little bit more to go in terms of using the idea of how can I prevent cancer for this patient in front of me, and say that every time they see them. I mean, we always think someone comes in with a headache or chest pain or swollen ankles or anything. We think, well, it could be cancer. Let's make sure, that's in our mind. But can I prevent cancer in this person to the best of my ability is something that I think we can move forward to in our prevention education.
Great, thank you. So I was thinking in the last 15, 20 minutes we have here, we would turn our attention to solutions. And that was a nice segue into, the patient-centered solutions. But I'm betting that Elsie can probably talk to us a little bit about population-wide or community-wide solutions, and maybe you can tell us a little bit about what's happening with Acadia.
Sure. Yeah. Sure. Thank you.
Yeah.
Yes. Great segue, because I think this panel brings home for me how much of a collaboration is required to really make a difference. And for us, we work, as I mentioned, in partnership with so many partners, individuals, volunteers, and it's infectious in a positive way. It's inspiring, and also it can create the kind of population level change that we need. No one organization or no one healthcare provider can make the difference that we want to see globally to have less cancer overall, to prevent, all the preventable cancers, et cetera, to get people access to early treatment. So for us, we very much work in partnership with healthcare providers. We know how important that connection is, and then we also think about, from our corner of the world and from our part of the puzzle in community health, we think about how do we reach people and how do we impact in sustainable, long-lasting ways to the best of our ability. So we think about PSE. You've probably heard that maybe in the public health world, populations, policy systems, and environmental changes. So we do a lot of programming and a lot of services and a lot of education, and we also try to think about how can we change policies, how can we change whole systems, and how can we change the environment around us so that, even if our particular educational program were to go away, that there will still be better health outcomes, that people will have better access to those healthy choices. And so, that includes, I was actually talking to a high school teacher over here a minute ago who's asking about if we engage youth, and I'm thrilled to hear that there are some high school students here. We do engage. We have actually one staff dedicated to, he's a youth engagement coordinator, and he works with high schools all around our region to engage and empower youth to take action, both in their school environments and in their communities. And so they look at how can they lead high school policy changes. So maybe that means increasing physical activity at a policy, sort of at a school policy change level, having more opportunities for recreation, for across. Maybe you don't play a sport, but there are going to be equal opportunities for you to have great physical activity, because again, we know how critical physical activity is, and creating those habits and patterns early on. Or maybe they're looking at their school lunchroom and not happy with the nutrition opportunities there, and looking at improving those. And so that's just a little snippet of some policy changes on a small level that can have long-lasting impacts, because then you have that policy change ideally forever and continue hopefully to grow on that. We also look at municipal policy changes around creating more tobacco-free spaces, creating, and doing lots of promotion about that. So then you both make it so that fewer people are exposed to tobacco, and you change the culture. So by doing both the policy and the communications and the engagement, you can change the culture, continue to sort of improve and change the culture, and also just literally make it so that less people are exposed to tobacco. We think about reaching people where they are. So in addition to those kinds of programming, we do have nutrition educators who go out into the school systems from pre-K on, and make nutrition fun, and do lots of great programming around taste testing new vegetables, and doing lots of just fun programming, connecting it to local vegetables that you can grow at home, and so again, it's a curriculum that they provide, some very all sorts of based on evidence, but it also engages individuals, from an early age on, their take-homes to bring to their parents, and so again, hopefully that's creating a new sort of systems within those individuals and those families and those kids, so that they're making healthier choices and knowing that nutrition is fun and easy. And then we also do nutrition education classes for the communities as a whole, with a focus on lower-income individuals, experiencing lower income. We do healthy food shopping on a budget, so all sorts of things that again, both expand, and it's open to anybody, but we sort of particularly target the areas that have higher levels of individuals experiencing low income, so that we can start to reduce those disparities, and reach people who may not even be going to a provider right now because of their insurance rates. We do still have very high uninsured rates and very high underinsured rates, and so that leads to all sorts of disparities and lack of access. And so we really try to hone in again on the areas and the communities and the ways that we can start to break down those disparities and reach people who really need it. We have a gleaning initiative. Some of you may have heard that. It's sort of taking off, I think, in various places around the country. When we started around 2012, it was still pretty new, and it's based on a biblical term, gleaning, which is getting the wheat that's left in the farmer's field. But it's all around, for us, we engage volunteers, community members, partners, and we partner with farms primarily, although also some retail stores, but primarily farms. We've got a lot of farms in our region, and we partner with them, and there are many cases where the farmers, for whatever reason, there may be a crop that they can't sell, it's not marketable, but is absolutely healthy. We always want to make sure it's high quality, and so then we get volunteers to go out and harvest that food and then distribute it to the food pantries and soup kitchens around the region, and so we have gleaned hundreds of thousands of pounds over the last few years and gotten that to people who need it most through that network. So again, that's partnering with farms, it's partnering with food pantries and soup kitchens, and then along with that, we send recipes. So we'll have recipes that go along with that gleaned kale. So because some people may not know quite what to do with kale and not realize how delicious it is. So there's lots of things like that. We do a lot of tobacco cessation programming. And again, and so one other quick example, disparity that's connected to our rural region, but also our cold region, is that we have, a good half of the year for people who, don't have studded sneakers to run, or it's hard to get out and about and be physically active. And as I mentioned, very few community centers, very few gyms. There'll be spans of sort of an hour where you don't have, you'd have to travel an hour to literally get to a gym or a community center. And so we started opening up schools, working with schools to open up schools in the morning. So we think about what resources are in most communities, and some businesses that have large layouts and people can come before the school day and walk around the gym. So community members can come in a safe place where they won't get hurt and slip, and we don't want that to happen, and so can come in and get physical activity in a social, fun environment. I think I'll stop there, but yeah, lots of things like that we're excited to be moving forward.
So it's clear, obviously, that this is, multiple sectors, multiple levels, right? There's got to be a lot of partnership, everything from medicine to the community to make this prevention initiative work. So, David, you had hinted at the use of technology to address some of these disparities, and I'm wondering if you could expand on that just a little bit and tell us exactly what are you thinking about in terms of the 5G and the phones, and like what would those solutions look like?
Well, first of all, foundational to all that is everything these remarkable people have said. It is about understanding the problem. It's about understanding that relationships are fundamental to the restoration of health. Health doesn't happen in isolation, but in rare cases, right? We know that. Education is fundamental. Insurance, access to resources, access to the providers, forming relationships. And then something you said, which I think is very important to the segue to technology, is reaching where the person is, where the family is, reaching them rather than this old expectation, the old paradigm of going to the doctor that's going away, or it's impossible in many circumstances. So how do we take care, which you do all the time, to where people are? And the question is, can technology help us with that task? I would argue that what is coming, and then I would say this especially to the students, that learning the application of digital healthcare to the curriculum, whether it's in nursing or medical school or in the allied professions, is going to be a fundamental part of what you're going to need to do, because you all carry this. It's a tool you use. And when I think from an epidemiologic perspective, that when we look at healthcare in the future, we will look at high cholesterol, we'll look at obesity, we'll look at level of education, we'll look at the things you described, and we will also say, and what is the bandwidth of that community? Because we will begin to understand the correlative relationship between access to the tools that this provides in terms of education, about diet, about connection to other people when they're isolated, about exercising in the cold weather when you can't get outside, whatever it might be. The apps that are available here are phenomenal. And they then expand to peripheral devices. I'm a guy from West Virginia, so we got lots of things that are wrong. I have AFib, for instance, and I have a device that I put my fingers on, my two lead fingers, and that sends to my cardiologist my heart rhythms. If I think I'm in AFib, it sends him, and he can review. Plus, there's an AI engine in there that tells him long before he even looks at it that it was a normal rhythm, right? And so this tool, plus understanding how it then is in the hands of so many of our patients in rural areas, even globally, there are more smartphones in Ethiopia than there are toothbrushes. I mean, seriously, there are millions and millions of these out in the world. And so then you begin to say, in what other ways can this be used? For instance, we have a mobile mammography program at UVA where we not only realize that distance is a barrier to screening, and so we take mobile mammo to women, but then we expedite the sending of that image and have an expedited review for suspicious findings, so that then on the screen, the mammographer, she can come on and she can talk to the woman and say, we need to get a diagnostic mammography. And the nutritionist from the health wagon can take that person with their $20 incentive card to the Food Lion to get better food, but can also ensure that they get to their diagnostic mammography. We do telecystoscopy, so we do screening for cervical cancer. We do telecystoscopy. There's a high rate of bladder cancer within patients who smoke, right? And how do we screen for that? And now we have developed a process to do telecystoscopy. And who's doing that? Nurse practitioners, because nurse practitioners are going to be front lines in many of the disparate areas to be able to provide health care, and connecting them to a specialist urologist in Charlottesville and a nurse practitioner in Laurel Forks, and allowing the bladder to be seen and surveilled in real time with fiber optic. These are the things that are going to be at play. How about type 2 diabetes? We all know this is a huge problem. Now there's the capability of a simple device that's held on the eye. Fundus exam is taken and is sent over the internet to an ophthalmologist through an AI engine, I might add, to rule out those cases. This is an FDA-approved device now to rule out those who don't have it so that they can see those who do. We're only limited by our imagination, and I see great promise for cancer control. I see great promise for health care in regions of geographic disparity, but it is up to all of us in a place like this to say, do not enable a digital divide between the poor and the rich in the access to broadband.
Great message. I think another area where we need all of us to be engaged is in policy advocacy. And I know, Grant, you've had experience with successes related to Medicaid expansion in addressing disparities. So I wonder if you could address that.
Well, so it's an interesting question. So in some of what I've talked about in my last question about how the lack of insurance is a very clear sort of way of dividing people who get screening versus don't get screening. And so you might sort of initially think, well, let's get people insurance, and then we'll see those rates shrink. We'll see those disparities shrink. And we've actually kind of had an interesting a little bit of an natural experiment with Medicaid expansion in various states. Some states did it, some states didn't. And so there have been some interesting research studies in the last few years which have looked at how various types of health disparities have changed, cancer screening being one of those health disparities that have been looked at. And interestingly, granted it's been a short period of time, most of these studies are looking at the last 3 or 4 years, but there hasn't been a tremendous change in between the disparities that existed with folks who didn't have insurance but then got Medicaid. Versus those who were insured during the time of expansion. And sure, there have been some improvements. They've been small in the places where you have seen it's been about 3% or so improvement in definitely in colorectal cancer screening rates. But you might ask yourself, well, why? Well, one, it's a little bit of a short interval to really get the robust kind of data to make more definitive statements about it. But health disparities are a lot more than just the policy prescription of get more people insurance. And I'm all in favor of getting everybody in the country insurance. I think that's a terrific goal. I hope it happens someday. But just because we give everybody insurance doesn't mean we're going to magically have all the disparities go away. Somebody that's in rural West Virginia or Appalachia or rural Florida, just because I give them insurance doesn't suddenly mean that they're going to have access to all of the necessary preventative testing, the ability to follow up abnormals with the necessary treatments. Doesn't mean they're able to get to the clinic just because they have insurance, right? You got to have a car that works, okay? Speaking about other chronic diseases other than cancer, if I have diabetes, I have to have reliable utilities to keep my refrigerator running, to keep my insulin working, right? So there's all sorts of things in addition to just having insurance as a policy recommendation. So we've got to look at a whole host of things in terms of policy. We've got to look at the built environment, and we've heard folks on the panel sort of allude to that. If we know that better diet and better exercise leads to lower cancer rates, we've got to make sure people with low income have access to green, safe spaces where they can exercise. So when I tell somebody, hey, you need to go get 30 minutes of exercise every day, well, if my neighborhood is unsafe, or it's filled with smog, or there's lots of traffic, there's no safe place to walk, I'm basically giving a person a recommendation that they can't fulfill, right? So we've got to, on the policy front, look at how do we get people safe places to exercise? How do we get people access to healthy foods at an affordable price, right? How do we increase levels of education, which we know will improve overall health outcomes? So we've got in Alachua County, where I am, we've recently done some updates to our comprehensive plan, and I was a part of the Healthcare Advisory Board section, and we basically titled our sort of proposal a health in all policies perspective. And basically what it says is, we don't care if it's a transportation policy or if it's some sort of policy governing the type of real estate type of businesses that are able to be built on this side of town versus this side of town. All of those decisions affect health outcomes. And so we have to be mindful of that when we're making these policies. How is this going to affect people's health in the air? How can we craft this policy or this change such that it reduces health disparities rather than increases health disparities, right? And so there's a whole host of other things outside of just health insurance, which I think the lesson of Medicaid expansion has kind of taught us.
Mm-hmm. Great. Thank you very much. And Tricia, can I give you the last word? And I'm wondering if you could, since your expertise is on healthy lifestyles and prevention, one of your areas of expertise, if you could provide just some words of wisdom, especially to the folks in the audience that happen to be in the younger set, in terms of what we should all be doing to prevent cancer.
So, I think one of the things I talked about in nutrition and how it there's evidence that it does prevent cancer, and how do you help patients? How do you help your community? How do you help people around you change behavior? And it's complex. It's human nature to want to do what's easy, and our culture over the last half a decade has really made it very easy to eat foods that are unhealthful, and I guess looking at the U.S. Department of Agriculture's 2012 consensus, it shows that up to 70% of the foods we're subsidizing are for farmers growing just 3 crops: soybeans, corn, and wheat. And those crops, 2/3 of those go to animal feed, so we're also subsidizing meat and dairy. Yet the USDA My Plate, which is a guide for people to make healthy choices of what to eat, 50% of that is vegetables and fruit. 2/3 whole grain and 1/3 of protein, which could be meat or nuts or beans, and only less than 1% of vegetables are subsidized. So it really makes a difficult opportunity for people to access, not only if it's not available in their community because of food deserts that we talked about, but also the cost of it. And so promoting healthy, promoting subsidize of vegetables or community gardening, community farming could bring more access to more citizens, and so I think that's one thing. And then the other piece I think is encouraging physicians to be experts on nutrition. That's something we can do as providers, and use food as medicine in a clinical setting. I think those.
That's wonderful. Thank you. I wish this conversation could go on all afternoon because these guys are absolutely amazing, but we have to wrap it up, so please help me thank them.
Thank you.